So today we're going to be talking about really kind of a broad overview of who do we take care of? And then once we take care of them, how do we fit into our regional as well as our national system? And then how does that really kind of look like on a day-to-day basis? What do we do when a patient with a special pathogen presents to one of our emergency departments? So first, we probably should define what is actually a special pathogen. So a special pathogen has one of these three attributes, or I guess a combination of these three attributes. Has to be hazardous, infectious, as well as communicable. Think really, really bad illnesses, right? And if you have any one of these three attributes, it's not particularly concerning. It doesn't necessarily need to be isolated into a biocontainment unit. Because if you can imagine, if I get botulism and I come home and I cough on my loved ones, they're probably not going to get botulism. Or if somebody gets norovirus, well, it runs rampant through cruise ships, right? It's communicable, passes person to person really easily. And while somebody with norovirus might feel like they actually want to die, they're probably not going to die. It's really not that hazardous. But when all of these things come together, you have what we consider as a special pathogen. And these are going to be the viral hemorrhagic fevers like Ebola, Marburg, Lassa, and the non-viral hemorrhagic fevers such as like MERS or smallpox. In the United States, we have 13 regions, and in these regions, we have highly specialized centers or level 1 centers, which are the Regional Emerging Special Pathogen Treatment Centers, or RESPECTs. We belong here in Region 3 on the East Coast, and in our region is DC, Maryland, Virginia, Delaware, Pennsylvania, and West Virginia. In our region, we have 2 level 1 adult facilities, so it's us and Johns Hopkins, and our pediatric partner is Children's National Hospital. At Washington Hospital Center, we have a dedicated biocontainment unit on 1F. By day, this is our observation unit. But if our center were to be activated and we were to accept a special pathogens patient, we would then, of course, safely move these patients out to other places within our hospital. And this would be converted into our biocontainment unit. From time of activation into receipt of patient, we have to be ready to go within 8 hours. And we'll talk about the activation tier a little bit later. Our capabilities, we're capable of treating or caring for 2 patients with viral hemorrhagic fevers or up to 10 patients with novel respiratory viruses. And that's a requirement of all level 1 facilities. As part of a level 1 facility, we also conduct outreach across our area, across our region, and we really coordinate almost in a hub and a spoke model with our other level, the other centers in our area to coordinate care for these really highly specialized patients. So within our region, we fit into this tiered response approach with the National Special Pathogen System from a level 1 to level 4 facilities. So we are a level 1 facilities, as is Hopkins and Children's National. And like I said, our capacity is to care for 2 viral hemorrhagic fever patients for at least 7 days, but really for the duration of their care. The requirement to be a level 1 facility, in addition to our outreach programs, are also we are required to train quarterly. So as a team, as a group, with all of our different specialties which are involved, train quarterly. We practice skills quarterly as a team, and we get down to the nitty gritty. So we're just basically prepared at any moment's notice to take care of these really, really sick patients and to keep ourselves and our staff safe as well. Level 2 facilities, so these are our special pathogen treatment centers, much like the level 1 centers, have the ability or capacity to deliver care to these really sick patients. They have to have the ability to care for 1 or 2 viral hemorrhagic fever patients for the duration of their care. But they don't provide that community or regional outreach like the level 1 centers do. And one of the other capabilities is that they aren't required to provide OB care, which level 1 facilities do. In our region, there are 8 level 2 facilities in Pennsylvania. There are 2 in Virginia at UVA and VCU, and 1 in West Virginia at West Virginia University. The level 3 centers are also known as assessment centers. These are really widely available and accessible centers, and they have to be able to have the capacity to identify these patients and care for these patients for up to 36 hours, so a much shorter duration of time. And once these patients are identified, they coordinate with the level 1 centers to really get these patients to a level 1 or a level 2 facility. Our level 3 facilities in the region are all in Virginia, and these are going to be Valley Winchester, Centara Princess Anne, Centara Lynchburg, and Mary Washington. And then finally, our level 4 facilities, these are every other hospital. The responsibility of these facilities are really to identify a patient of interest, to isolate them, to keep the patient themselves safe, as well as everybody else within that emergency department or within that hospital, the other patients and the staff, and to inform the greater public health infrastructure, including our level 1 facilities, to get these patients to a higher level of care to safely care for these patients. And none of this would be possible without a really coordinated EMS and a public health response to be able to safely move these patients throughout the region and to keep our community safe.
All right, I'll take over from Dr. Mueller. Now, good morning, everyone. Thank you very much for the opportunity. As Manish said, I'm Aaron Resnick, the Biocontainment Unit Program Director here at Hospital Center, and I'll just walk you through the next couple slides. And so really just a bit of who we are, if you are potentially transferring a patient to our Biocontainment Unit here at Hospital Center here on 1F, as Dr. Mueller noted. So perhaps to start off, there is no singular 24/7 BCU clinical staff member. The core team that we have is a fully volunteer force composed of more than 70 physicians, APPs, nurses, and ancillary staff on the inpatient side, along with over a dozen each from our laboratory team and MedStar transport team led by Dr. Sasser. Our inpatient team is led by the critical care service line and ICU nurses. It's a wonderful team, and we're extremely fortunate to have additional team members from a variety of our strategic service lines, both clinical and non-clinical, that you can see on the screen here to help us ensure that we have a full complement of patient care services. Dr. Mueller noted that as a level 1 facility, we are on point for treating any and all patients, including pregnant patients, including potentially delivering a baby. In our BCU, we have that capability. We've practiced that capability. Our unit also includes an in-unit lab down the hall from our main patient rooms, and we have the ability within the unit to perform surgery, x-rays, and as mentioned, deliver babies among other services. And I also want to point out, you see the list in front of you, and particularly note emergency medicine. Dr. Marisha Lorenowitz is our relatively newly appointed BCU emergency medicine lead, and she, along with Drs. Mueller and Sasser and our BCU leadership team, can act as another point of reference or resource if you have any questions, following this presentation. We can move to the next slide, please. So now we want to discuss how you can think about and really approach a suspected special pathogen scenario that Dr. Mueller laid out to keep really yourselves, your colleagues, and your patients safe within your practice. And for that, I'd like to turn it over to Dr. Matt Sasser.
Thanks, Aaron. Really appreciate it. So as you've already gotten the background for what Washington Hospital Center is as a regional emerging special pathogen treatment center, now we're going to focus down to the emergency physicians and what do we really need to do. So the most important things for us are going to be really 3 things. We have to identify, isolate, and inform. So what does that actually mean? Well, I mean, it's pretty direct in terms of identifying patients. So if these are patients with viral hemorrhagic fevers, if they're bleeding out of every orifice, that's going to be very easy to identify. But in reality, that's actually not going to be how most of our patients present. In general, they're going to present with very vague symptoms. They're going to have fever, nausea, vomiting, fatigue. So it's going to be basically like every other patient that we see during the viral season, right? And, can these patients potentially, present to one of our Maryland or DC hospitals? Absolutely. The most recent case in the US of Lassa fever happened in Iowa, of all places. It was somebody who actually had a trip to Africa where they contracted the disease. So, we have to have, and I hesitate to use the term high index of suspicion, but it's one of those things that we always have to think about given the potential morbidity and mortality. So where does this really come down? It comes down to who's going to be doing the identifying. And oftentimes it's going to be the triage nurse who's the most important person here. So the questions that you're going to have to ask yourself is, how does your hospital handle travel screens? When the nurses are doing all of the travel screens, are we reading all of that documentation? I mean, I know that I read everything that the nurses document, including their documentation of the right middle lobe lung sounds, every single time. Are there notes that are being put into the Cerner FirstNet system? For example, are they putting it saying recent travel to so-and-so? I think that would probably be a possible reasonable, way to fix or way to identify that. But really what you need some kind of epidemiological link. So right here, this is a picture of obviously Washington, D.C. with our 2 major airports, D.C., but the more important one is going to be Dulles International, which is an entry point which does have a CDC screening center for I should say, flyers who are coming from areas with potential infection. So just to give you an idea, currently there is an outbreak of Ebola that most people probably don't even know about. It's going on in the Democratic Republic of the Congo. There are 63 people with suspected or confirmed Ebola, including 16 deaths for healthcare workers. This is the 16th outbreak since 1976. Other recent outbreaks included Marburg, which occurred in Rwanda and Tanzania. So it's really important to actually understand that, travel history is very important. So once we identify a patient, well, then we have to isolate them because we don't want other people to be sick. So the questions that you're going to have to ask your own hospital is, where are you going to isolate your patient? What does that room look like? Is it negative pressure? Does it have a window? Do you have a camera available to set up to monitor the patient? It doesn't have to be super fancy. It could be a baby monitor. How are you going to mark that room so that nobody else goes in? A great example of this is we performed an exercise at one hospital where we had a patient pretend to have all of the identical symptoms. He did a great job acting. And even though we had this purple diamond up here that says check with the charge nurse before going in, we had EVS come in to the room as the patient was acting. We had supply come in to help stock the room. So it's really important to help identify that room and isolate where your patient's going to be. How are you going to get your patient there? How are you going to decontaminate the route after you get your patient there? Are you leaving a trail of contaminated body fluids along the way? You really need to isolate the waste in addition to the patient. And then the next most important thing is going to be to inform. Who are you going to inform? And there are going to be multiple phone calls here, not just one. And I'll turn it over to Aaron for this next part.
Yeah, I think Dr. Sasser set it up pretty well in terms of there's going to be several people that you're going to want to inform, several entities. And of course, the question is, who are those folks? So you can see that it's scrolling on the screen. So much of you who you would want to inform is going to be similar to what you would do with other notifiable disease conditions, such as your local infectious disease and infection prevention colleagues within your hospital. They would likely then in turn liaise and work with your local public health agency, whether that's at the state or local public health levels. And really the key is the middle section, I think, for you all, that to get the ball rolling in terms of potentially if you suspect a special pathogen case based upon some of the criteria that Dr. Sasser laid out, really the key for informing us within the biocontainment unit and to potentially start that process for transferring a patient over is contacting MedStar Communications and requesting the hospital center infectious disease attending physician on call. And that would sort of spark a tiered activation environment that would involve the BCU leadership team, involve hospital leadership here at hospital center, and that ultimately, if the right conditions are met, if it makes sense for everybody involved, transferring the patient from your care over to the care of our biocontainment team here at hospital center. So really, sort of like to some extent, one number does it all within MedStar. That's starting with a number that many of you most likely are familiar with, contacting communications, then asking for our infectious disease attending physician on call to get it started.
Great. So now you've identified, you've isolated, and you've started to inform. Now what else do you have to do? Well, let's not forget we have a patient here, so we have to ensure that we're taking care of the patient themselves. So a lot of times, like I say, it's going to be early in the disease process. They might come in with fever, nausea, maybe not too sick, but you still have to understand that we still have to provide patient care. So after you've started patient care, obviously you want to be safe, and we'll get into PPE in a moment. Once you've made those phone calls to MedStar Transport, we have a lot of work to do. So number one, we have to get all of our people together. Not everybody from MedStar Transport is part of our special containment pathogen transport team. They are volunteers within our unit, so we have to make sure that we have the right people. We also have to make sure that we have the right ambulances, because we aren't able to just send one ambulance. These kind of transports require 2 ambulances fully staffed. So we need to make sure that we have a treatment vehicle as well as a support vehicle. And on top of that, we also have equipment that we need to get. This requires specialized equipment that is generally housed at Washington Hospital Center. So we have to have our team go to Washington Hospital Center, stock up the ambulances, and this is before we can even get to the sending facility. So how do I take care of my patient? Well, you're going to see us show up in this kind of PPE at some point. We might not arrive in it. We might put it on when we get there. But the most important thing is you need to be familiar with your local PPE. It's going to be different in different hospitals. It's going to be different or it's going to be stored in different areas. And generally, you're going to think about this as droplet precautions plus. So we all know what droplet precautions are. We just came off of COVID. But the question is, what is the plus? And because these pathogens are potentially so dangerous, the plus is things like boot covers to cover your legs, long gloves. So for example, I had one patient where he came in with fever, nausea, vomiting, and the note in the system said recent travel to Africa. Well, what did I do? Obviously, alarm bells are going off in my head, but I didn't get dressed full top to bottom. We made sure that the patient had a mask on. I stood at the doorway. I was in face mask and 95 gown. I was more than 6 feet away. And that's when I started getting my initial history, and I realized that there was no epidemiological link. And so I was able to treat the patient just as a normal patient. How do you communicate with your patient if you do have that strong suspicion? Again, this is going to be whiteboards. It can be cell phone communication. You can just call the patient directly in their room because we are generally going to have that phone number, and you can even yell through the door. Standard laboratory testing is going to be generally pretty tricky. And that's going to be part of the discussion with the BCU in terms of exactly what testing needs to get done prior to transport and what can get done locally. So obviously, if we have a patient, we need to take care of them. Most of these patients, again, are not going to be sick. But what if my patient does decompensate and I have that concern? Well, if the patient is bleeding out of every orifice and then they code, they are probably at the end stage of their disease. And so there is a discussion within a lot of the programs that we would potentially not code these patients. But if a patient is walkie-talkie, they look good, they've had vomiting and they've had diarrhea, then they might actually not have a viral hemorrhagic fever. And in fact, most of these patients are going to rule out and they're going to have something like malaria, which has very similar symptoms. So malaria, obviously not the same level as a viral hemorrhagic fever. I think that those are patients that most of us will code, understanding that we do have to put our PPE on and take care of ourselves first. Again, that's going to be a very internal discussion and something that we would want to do with an internal briefing with our team ahead of time. So what do I do to prepare for MedStar Transport's arrival? We're going to ask that you prepare a place for our team to don full airborne PPE. We use full airborne PPE because we want to be very safe. We are in a less controlled environment than a hospital. We are getting in and out of ambulances. So that's why we take that extra precaution. Clear the hallways of obstructions, prepare the room for an EMS stretcher, and be prepared to decontaminate the path from the emergency department to the ambulance bay. And then what do I do after a patient departs? So you're still going to have to consider the need for waste disposal, terminal clean of the emergency department spaces and reusable equipment, staffing impacts and monitoring. You're going to have to coordinate with your local public health among other jurisdictional elements, as well as infection prevention and infectious disease, as well as occupational health. And don't forget that we do offer care for the caregiver support. Here are a couple of great resources. So obviously we have the MedStar Washington Hospital BCU homepage, as well as NETEC, which is the National Emerging Special Pathogen Training and Education Center. Great resources. They have the latest on all of the outbreaks. They provide additional information in terms of PPE protocols, biosafety transport for operators. Great resources. And I hope that we gave you a quick down and dirty discussion of what special pathogens are, what resources we have at MedStar. And I want to thank you for allowing us the time on behalf of myself, Dr. Mueller, Aaron Resnick, and we are happy to answer any questions.
Great, thanks so much. Questions for our presenters? Guys, I had a question about how you manage code status. And you alluded to this for an individual who comes in who's obviously critically ill and codes. Do we have anything that's written guidance on when we can stop resuscitative efforts?
So the short answer is no, we don't have anything specifically written. The little bit longer answer is going to be, so I guess our guidance would be for a lot of the community hospitals without the airborne PPE that may be always available. And ultimately, the biggest thing is keeping our staff safe. And so not putting yourself really in harm's way. At Washington Hospital Center, our biocontainment unit team, we actually do practice running codes in our biocontainment unit. And so we're prepared to do CPR and cardiac arrest management in our biocontainment unit. We have a dedicated Lucas device for our biocontainment unit as well. But because we're kind of a specialized center and we train with it and to try to reduce the risk of our exposure. But we don't have specific protocols outside of our hospital, no.
That's great. And just as there's another question in the chat, Dr. Geller, if you'd like, you can go ahead and share your slides. The other question is, should we involve our local ID consultants at any point?
Yes, that should be one of the first phone calls that we're going to make. So you can call your local infectious disease as well as MedStar Transport, which will connect you to Washington Hospital Center Infectious Disease, and they can help guide the rest of their response.
Okay, great. Any other questions for our presenters? All right. Thank you so much for the presentation. We'll move on to our next presenter, Dr. Marjorie Galler. Margie has been a pediatrician at Georgetown in the ED for the last 8 years. Her passions include physician wellness, medical education, and optimizing pediatric experiences in the ED. And she thinks that every single baby is beautiful. Margie.
Hey, everybody. Thanks so much for having me. And thank you for reading my introduction as written. So I'm Margie. I am one of the 2 pediatricians that works at Georgetown. My better half is Tammy Cotty, who you all know and love. I am so excited to come and talk to you about babies today and what we do with them when they have fevers. I'm not going to talk about Ebola. So yeah, we'll just move past that. Thank you to the brave team that went first. And all that you do with that. So the first thing I want to say is that because this is being recorded on YouTube, I had to go through and take every picture of my own kids out of these slides. And these are all stock photos of PowerPoint babies. So I'm sorry. If you want to see my kids, I'll show you another time. So here we go. Let's play. I have no financial disclosures. Okay, so our objectives, we have 3 things today. We're going to explore the new guidelines to managing a well-appearing febrile infant. When I say new, they're from 2021. We're going to practice applying them to 3 cases, and we're going to increase your oxytocin by viewing pictures of adorable babies. Case number 1, oh, so cute. She's 26 days old. She's a full-term baby. She was born by C-section for failure to progress. Negative maternal labs. And she comes in, she was a little bit fussy. She wasn't nursing as well today, and she had a single temperature of 101 rectally at home. Our next case is a 40-day-old male, and he is full term. He was born by spontaneous vaginal delivery, negative maternal labs. This baby's got a little bit of a runny nose, a little cough. He took a little bit less of his bottle, but he's making good wet diapers, as evidenced by the cute little blue line. And he had a single temperature of 100.8 today, also rectally. Our last case to keep in mind that we're going to go through is a 51-day-old female. So she's a senior citizen of our group. She is an X38 weeker, also born vaginally. She felt warm at home to her parents. They couldn't find a thermometer, but they said that the older sibling has been coughing all over her all day long or all week long. In triage, we've got a rectal temp of 102, and she's well appearing. So why do we care? Why is this important? So we know that babies don't have a lot of ways to tell us that they're sick. If they look unwell, we know what to do, right? Full court press, we're going to do blood, we're going to do urine, we're going to do CSF, we're going to start them on Vanc, we're going to start them on cefepime, we're going to start them on acyclovir, they're going to go to our PICU. Because if they're sick, they're already down the hill. But if they look well, they don't have a lot of good ways to tell us that they're on the way down that hill. So up to 6% are going to have one of these invasive bacterial infections, so bacteremia, meningitis, or sepsis, urosepsis, it's supposed to say. But since the 1970s, this balance of like doing too much or too little, we've been actually on the side of too much. We've been admitting so many babies, LPing so many babies, and exposing them to broad spectrum antibiotics. So how do we find the balance? I will take 1 second to say that we are doing so well in this fight because of vaccines, which are safe, effective, and should be offered to all of your patients. Please take every opportunity you can when you're asking patients about their immunization status to congratulate and thank parents wholeheartedly when their child is up to date. And if not, to begin a conversation of motivational interviewing. Every single interaction makes a difference and puts a little extra stone on the scale of vaccinating. Oh, is there a question? No,
Nope,
there's no
hit the wrong button.
Oh, but yeah, woohoo, vaccines. So let's move forward. These are the guidelines we're going to go into today. They're from 2021, but the great news is that they've actually been holding up well to the test of 4 years' time. What's different about this versus like the Rochester criteria or the Boston Children's that you might have heard about from like back in the 90s, this actually breaks us into 3 age groups, 8 days to 21 days, 22 days to 28 days, and then the 29 to 60 are senior citizens. And the whole idea here is to figure out who do we need to do what for without missing the big bads. So here's the data from 4 large trials that basically showed us that we can break it out into 3 groups and that it's important to do so. So you can see that in the youngest babies, and so they use 8 as the lower edge. Practically speaking, we just say anytime after you've been discharged from the hospital. And that's like sort of an update in the last 4 years. But you can see here that those earliest babies can have up to 5 or 6% chance of these invasive infections. But then when you take a peek at those older kids, you're down less than 1% or at 1%. So we want to make sure that we're considering everybody individually. So our inclusion and exclusion criteria are always really important. So remember, these are for well-appearing babies. These are not for sick-appearing babies. We're talking about rectal temps with the big asterisk that if you have actually an axillary temp that it was taken at home, we want to trust it. If it was over 38, you want to retake it, but we're still going to do the whole thing because it's only like, there's a couple studies that show it's like 0.2 or 0.3 degrees Celsius higher, and it's too close for comfort. If it's a temporal monitor, like the random number generator, then you can be a little bit more suspicious, and you have, ideally, they bring the random number generator with them to the ED. Nobody does, and you can compare it, but you do what you can, and that's, so axillary we take as a true value, even at home. Temporal, there's a little bit of gray. We're talking about full-term babies, so greater than or equal to 37 weeks, and we are still including babies that have URI symptoms without bronchiolitis, those loose stools, and otitis media, which is very difficult and very unusual to diagnose under 2 months of age. So you want to think twice, and even positive viral testing. We're going to exclude everybody who was born prematurely before 37 weeks. If they have a focal bacterial infection like cellulitis, clinical bronchiolitis is an exclusion as well, and that's going to be important for this upcoming season. Complex history, so anyone with a complex neonatal course, anyone who's got a congenital or chromosomal abnormality, or medically fragile infant, so someone who has a trach or a G-tube or anything that just increases their complexity. And then you'll notice here, immunizations in the past 48 hours. So we know that babies get their first Hep B vaccine ideally at birth in the hospital, and their second one is either at 1 month or at 2 months, depending on your pediatric practice. Up to 40% of babies are going to have a fever over 38 degrees with any within the first 48 hours after a vaccine. So we want to keep that in mind. Generally speaking, their next set of vaccines, the ones with the DTaP and our strep pneumo and the really good stuff, that is not going to happen until 2 months. So that usually is not going to come up here. But think about the Hep B, because that's the only one that they're usually going to have received. So let's just go through these algorithms. No big deal. Woo! Look at those flowcharts. They're crazy, and I have to tell you, Cliff Notes, they say may and could and might over and over again, and it's a little confusing. I always go back to these every time I see a baby with a fever, but I'm going to break it down and make it easier and give you some more generalities, but of course, always go back to the source information. So approach based on age. every all-comer between birth and, well, I should say hospital discharge and 60 days is going to get their blood drawn for inflammatory markers, a blood culture, then they're going to get a urinalysis and a urine culture. The method of getting that urinalysis is going to be either bag or cath. You can try to get a clean catch. I've done it twice. It's really exciting, but rare. And a urine culture, I'm going to say this 10 times, but don't send it off of a bag, please. But more importantly, send it rather than forgetting it. And then some get CSF, and we'll drill down now. So let's talk about inflammatory markers. Procalcitonin is our new-ish friend. We got it at Georgetown to be run stat. I think it was 3 or 4 years ago, and it was really exciting. I saw that a couple of our hospitals have it now. I don't know if there are any last holdouts that don't have a stat procal, because it's very important and it's sort of the standard of care now. So we can, discuss that if necessary. One really important thing here is that procalcitonin, the limit that we're using is 0.5 nanograms per milliliter, but please note that your lab indice will indicate elevation greater than 0.05 nanograms per milliliter. And if you call and try to admit a patient with a positive inflammatory marker, but it's actually only 0.06, it's okay. The pediatric hospitalist won't laugh at you. Pediatricians are friendly, but they will, it will have been an unnecessary call. So remember, 0.5 is the cutoff. CRP is a little less useful. 20 is the cutoff, an ANC of 4,000. And then you'll see that WBC is not here because it's just really poor sensitivity. It's a poor marker. Temperature is obviously not a blood test, but we actually see in a couple good studies that for every degree over 38.5, every Celsius degree, you have an increased odds ratio of 1.8 times. There's a question about a statistic. Oh God. Yes.
Marge, just a quick question about this CRP. If you're getting a procalcitonin, is there any role for CRP?
A great question. I usually do it because I can trend a CRP. So I do it for my hospitalist friends later on the road, but you could just get a procal. And if you get like a single drop of blood, get your procal.
Okay.
Yeah, you're right. We don't use them together. It's like yes or no binary. For urine, we want to get microscopy whenever possible. You're going to be looking for leuks, nitrites, bacteria, the usual, and then our cutoff is 5 cells per high power field. If you've done a bag, please make sure that if that's positive, that you repeat it in a cath sample and then send the culture. And I spoke with a couple of my cool peds hospitalist friends, and their major things they wanted me to convey to you was, first of all, thank you so much. They're always available as resources, and please send a urine culture because when we don't have the culture data, we are sort of adrift later on. So CSF studies are the classic ones. You'll notice that the tubes are a little bit different. Yes, it's great if you can get 4 beautiful tubes of champagne tap to send to the lab, but if you've got a dehydrated, well, hopefully they're not dehydrated, but a baby who doesn't have a lot of CSF to give, the culture is the most important, and then you really want that cell count. Everything else is gravy. You're going to notice that the cutoff for pleocytosis, under 28 days, we're positive over 15 whites per microliter, and then 29 to 56, it's 9. Okay, so there are age differences, and the ranges are usually accurate on our MedConnect, but not always. One quick plug here for enterovirus PCR. If it's summer or fall and you have a baby with a fever and they're well appearing, it's a great thing to get. The enterovirus PCR can come back within 12 to 24 hours. And generally speaking, you can actually stop all antibiotics and send them home. So that's great news. And then HSV. Can't have a conversation about febrile babies without HSV. Often they're sick appearing, but sometimes they're not. So if there's any maternal history of HSV, either before delivery or they got a fever and had an outbreak even within a few days after, if the baby had a seizure, if the baby has any vesicles or funny looking rash, or if you've got CSF pleocytosis without a positive gram stain result, you really want to think about HSV. And if you even think about it and send it, please add the acyclovir. We can always take it off later, but Out of all the things we're discussing, of course, meningitis has the worst morbidity and mortality, and HSV is particularly devastating. And it's quick. Okay, so we're going to go in a little bit more detail about the specific guidelines. So we talked about these tiny little ones. We're going to do everything. And no matter what the results say, we're going to admit them. They're all getting admitted. Yay, you get admitted. It's a big deal, of course, to admit a baby. So we want to, I just take this moment to say, think about the stress that we're imparting upon a family at a very delicate time in their lives. We've got maternal hormones, we've got all the family situations. So we want to not be blasé about what they're going to be embarking upon. And we want to try to optimize their experience. But anyways, in terms of their medical care, we do AMP and ceftazidime, and we add acyclovir for suspected meningitis. Gent is also useful and is used at many other places. It's just about the antibiogram, and this is what we're using when it's available these days at Georgetown. And remember that ampicillin is for Listeria and GBS, and Listeria is, I would say, almost all gone, except we're having some issues with containing foodborne illnesses these days, so all this could change. Now here's our special little micro group, our 22 to 28 day of life babies. We're going to start with urine and blood for these guys, and it's all going to be about what we see in the results. Basically, if they have elevated inflammatory markers, whether or not they have a positive UA, they need an LP. They're going to get the LP done, and then most likely they're going to be admitted anyways. There is a possibility that if you have a normal CSF, you can give them a dose of ceftriaxone, be covered for 24 hours, and you can send them home for really close follow-up with their pediatrician like 12 hours later, 24 hours later. Practically speaking, I've never seen anyone do this because of that risk of a partially treated meningitis. And then just to say that if you have a positive CSF, if you think you have meningitis, you want to broaden to vancomycin and acyclovir. And if you have a dry tap, you just consider it like you never did it, and they get admitted, they get antibiotics and admission. Now, this is exciting. Normal inflammatory markers and a negative UA, they don't need an LP, but they still get admitted to the hospital. Some might say, wouldn't it be better to do an LP and have it be negative and then be able to discharge them home? The data doesn't support that. This is all sort of weak to mildly, it's not great evidence basically, but this is what we're doing. We're not sending these babies home without an LP. So I wrote, the only way, it was if the CSF doesn't drip, you must admit, okay? Okay. Our last group here are our senior citizens, and we're gonna get urine blood, and we're gonna go like this. So if we have, yes, a question.
Sorry, another question in the chat. I am assuming that's inflammatory markers. Is that just CRP and procalcitonin, or is it also white count, bandemia?
It's only our four. It's our procal, CRP, ANC, and that temperature. So
And temperature, okay.
Yes, so these four are our big four inflammatory markers in all of our discussion today. Don't worry about that white count or the bandemia. Babies have weird bands. Okay, so if you have negative inflammatory markers and a negative UA, guess what? They can go home without an LP and without antibiotics. This is the place where we've really made a difference. And that's actually a lot of the babies in the end. So really important to make sure they have to have a pediatrician, not like, oh, I'm going to go to this clinic tomorrow. No, they have to have an established pediatrician. They have to have a really good way of getting there. They have to feel confident. If the parents don't feel confident and they want to be admitted, absolutely they can be admitted. If there are any concerns whatsoever, the default should be admission. But negative IMs and a negative UA, you can start the conversation about discharge. If you have a negative inflammatory marker panel and you have positive UA, you just diagnose the first UTI. You make sure you get your cath urine culture. You give the first dose of ceftriaxone. Ideally, if you still have access. If you don't, you could do it intramuscularly, or you could even give Ceftonir orally for those older babies, but I would discuss that with somebody on the peds team. And then quick follow-up too, because that urosepsis risk is about 5 to 7% in this age group. Okay, this is where it gets a little bit more mucky. If you have positive IMs and a positive UA, you may perform an LP. What we usually do in practice is skip the LP, give antibiotics, and admit. So you're watching carefully and treating the UTI and being cautious of a possible urosepsis. The risk of meningitis is actually not very high. There have been a couple studies that have shown that the risk of bacterial meningitis is no higher in babies with pyelo than those without. So that's where we sort of feel okay about this. When we have positive IMs and a negative UA, this is also tricky, and I would say that I've seen it go a lot of different ways. When we say may perform an LP, usually we do. So the idea here is you've got inflammatory markers and we don't have a source. We still don't have a source, but we're worried. There's something going on here. So you're going to get the LP and you're going to admit. You could potentially, if you have a negative CSF, give them that dose of ceftriaxone and send them out. It's not likely. And the antibiotic choice here after 29 days is ceftriaxone. Before 29 days, we're not doing ceftriaxone because of the risk of kernicterus. Okay, this is just a summary slide that you can take a screenshot of. You can put it in your phone. You can delete it, whatever you want to do. But it's my distillation and Dr. Cotty's distillation of these guidelines. So another thing to take a picture of. Is anybody a Potterhead? Hands up. Yes, no. Harry Potter, yay! Help will always be given at Georgetown and Hogwarts for those who ask for it. So please put these numbers into your phone, the pediatric hospitalist pager and the PICU attending direct line. As of, I think 6 months ago, we now have a PICU attending in-house 24/7, so they will always answer that phone. It's amazing. And the reason that oh, hello, Dr. Hager.
Hey, Marge, I didn't mean to cut you off there. I do have 2 quick questions. For the inflammatory markers, is it 1 and you're done, right? So you're listed 4. If you have any one of those positive, is that considered a positive inflammatory marker? You're nodding yes.
1 and
okay.
done.
And then it seems quite clear based on this, and I just would appreciate your commentary on this, that there really is very little opportunity for clinical gestalt in these babies with fever, even if they look really, really well. Perhaps there's a questionable sick contact in the home or some other things that may tip you to say, well, this is likely viral. There's really no opportunity for clinical gestalt to sway us and not do this workup, is how I'm interpreting that. Would you agree with that?
Absolutely. And when you get to the cases, you're going to see that in action because babies will try to trick you and parents will too with sick contacts. So yeah, you can't, the baby is not trying. The baby is misleading you by its precious, healthy appearance. It is a ball of possible sepsis and we have to act like it. So guys, this is exciting for Georgetown. As recently as of August 2025, so last month, we basically are now asking everybody in MedStar South to preferentially transfer your patients to Georgetown pediatrics. So we have our PICU and we have our peds floors open. We've got our hospitalists and PICU attendings ready to discuss patients with you, whether they need admission or not. And they can always help you with the transfer. So I think that's really helpful. Oh, is a question?
Hey, thanks so much. That's great. For the MedStar North hospitals, if we are calling just to kind of get some advice, are we able to call these numbers or are these our first kind of contacts?
Yes, you can. Especially I'd say the PICU, for sick kids, it's a direct line, like ring away. Don't tell them I said that because they'll be like, oh, we want to sleep. No, they're super helpful, super friendly. So please call. And also the hospitalists as well. They're more than happy to help you and be a consult.
Great, thank you.
And I'll just to reinforce that, to make it incredibly clear, anyone working in any of our sites has full authorization, and in fact, it's welcomed for you to call our pediatric colleagues at Georgetown for advice. They stand by, ready, willing, and able to provide that advice.
Dr. Koo.
Thanks, Margie. Like the inflammatory markers are like a game changer and something that I wasn't taught initially, and so that's definitely changed a lot of stuff. I was wondering, I feel like I've heard like different things about like if they are previous between like before 37 weeks. Like what is your thought about like accounting for if they were born at like 34 weeks? Are we like subtracting those weeks?
Yeah.
And I don't know. Yeah, what are your thoughts about that?
So generally speaking, if they're like, I would say if they're 35 or above, I do like a corrected age. So they have 2 extra weeks where they're in that tiny little group. And I'm just more conservative in general because they tend to be, those kids can really get thrown off. They tend to have a little bit more trouble feeding. They tend to have more temperature instability. So just, yes, I do a corrected, but with like an asterisk of caution. Younger than that, especially if they had any respiratory support or they were exposed to antibiotics previously or had a considerable NICU stay, which they generally do, I'm much more cautious and I generally reach out to either their providers or if they're really little, like I think Tammy recently had a patient that literally was discharged from the NICU and had a situation like felt febrile in the car seat on the way out the door. Just call the NICU. They are also wonderful people and happy to help you. And I call the NICU for those babies.
Thank you.
All right. Oh, yeah.
Margie, there's a couple questions in the chat as well.
Oh, sorry. I don't actually know how to turn the chat on. Would you
totally
voice
fine.
them for me?
Yep, happy to read them. So the first question is, what if your lab does not turn around procalcitonin in a reasonable time? And I see a number of chairs on the call. I wonder if you're able to check at your respective sites if you have access to it in the emergency department and kind of ballpark turnaround time. But Margie, what do you think there? If you can't get a procalcitonin in a reasonable time,
you look at your CRP and your ANC and you act with caution. So always better to do more, always better to admit, certainly don't discharge someone because that procal is so important, and always better to antibiose. I will say we have this like one situation, right, where you can't get an LP on a baby and you're like, do I do the LP? Like, do I wait and have, like, do we try again or do we just give the antibiotic? If they're sick, give the antibiotic. We can always still get cell data later. We can figure it out once they get admitted. If they're not sick, that is something to discuss with the pediatrician on call, because sometimes we can make a really big difference in terms of the patient's course. If we have a well-appearing baby, we have everything else that's reassuring, and then we can defer like 6 hours for an LP once they're, at Georgetown.
Great. And then the other question is, for 22 to 28 days, if the inflammatory marker is a negative and UA negative, do we want an LP done at the local hospital or wait for transfer?
Great question. So you said when everything's negative.
Right.
Okay. You don't even get an LP. You just admit for observations and snuggles. Take a look right here. So those babies, they're just coming to be gazed upon and make sure that they don't do anything funky for about 24 hours. It used to be like 48 hours rule out for everything. Now the data shows that actually almost everyone who's going to be positive at 24 hours at all is going to be positive at 24 hours. Remember, guys, 70% of positive blood cultures in kids, I don't know about adults, they're contaminants. So the real stuff is almost always positive initially. And for the couple cases where it wasn't, at least it wasn't meningitis. So that made me feel better.
Just to put that in context, the last time we looked at this at Hospital Center, it was 6% for adults. There's been a lot of great questions, so we were kind of towards the end of our time.
Sorry.
But I wonder if you can just go through those cases quickly. I'm sure there's great points.
Yeah, I'm sorry, really fast. So for this little tiny one, we did to go back really fast. It's a 26-day-old, so we are in that 22 to 28 day range. The baby was well appearing, so we got the urine, we got the inflammatory markers, and sent a blood culture. Shared decision making with the parents. They were on board with no LP, no antibiotics, exactly like in this question. And they were just watched for 24 hours. They went home, and that baby is now a thriving kindergartner somewhere in the DMV. The next patient, oh, and so yeah, here's just like showing where we are in my little key points cheat sheet. Now we've got this 40-day-old cutie patootie who's got this rhinorrhea and mild cough. So this was a trick. On the exam, the baby actually has bronchiolitis. So polyphonic sounds, minimal retractions, just some belly breathing. The viral testing is positive for RSV. So guess what? They meet the exclusion criteria. So they come completely off this pathway. This baby didn't need blood work. This baby didn't need a chest x-ray. That can be a whole other lecture. Got some suctioning, did some eating, was monitored, went home, saw their pediatrician the next day. This baby is now a preschooler at a very prestigious local academy, doing great. And then our third case, this 51-day-old baby, so our senior citizen of the group with the sick contact, the red herring is that we've got a sick contact. It actually didn't make a difference. And viral testing, we can talk about RVPs and tell everybody to stop ordering them. They're cheaper now than before COVID. I understand why people do it. I do it myself sometimes too, but they have no role in this workup. The data is just not there. There have not been any prospective studies. So you can still get them, and I get them too for these babies a lot, but it doesn't go into the algorithm. It's not a reason. So this baby, remember their temp was 102, so that's a positive inflammatory marker, and the procalcitonin was elevated, 0.6 nanograms per milliliter. Their UA was negative, and they had this positive RVP. Shared decision making. The parents were like, actually, yeah, that makes sense. They're really febrile, and you're worried. Let's do an LP. You seem like a really awesome clinician. Said no parent ever when I'm like, here's a needle for your baby. We admitted the baby, held the antibiotics, and guess what? At 12 hours, that blood culture turned positive for E. coli. So we started cefepime stat. We did all the right things, right? This baby wasn't on antibiotics, but they were in the perfect place. They had the IV still from their initial blood work. We could get them started. And this baby is now also a very successful preschooler who specializes in singing Twinkle, Twinkle, Little Star. That is all I have for you guys. Thank you so much for your wonderful questions.
Great presentation. There's questions in the chat. I have a question as well. I wonder if you can pull the slides down so we can let our next presenter load up their slides.
Oh, absolutely.
And I think maybe Emily, did you have a question?
Nope, I hit the wrong button.
Okay. Margie, just to confirm, and I think you said this, the temperature that we should be using is always a rectal temperature. Is that right?
We should always take a rectal temperature every single time, no matter what, except for our transplant patients. Okay, but rectal temperatures. What I was saying was that if we have a parent that took an axillary temperature at home, we're going to trust them. We're going to use that number and say that it was a fever.
And particularly if it was greater than 38.5, correct?
38 flat.
38, sorry. Okay.
A fever is 38 flat, 100.4. And to be considered an inflammatory marker elevated is 38.5.
Okay, great.
Sorry, I know it's itsy bitsy. You can also always ask me, and I will put a link to these guidelines in the chat right now.
Fantastic. Thank you again. Great presentation. We will move on to our next presentation. This is Emily Haley and Kelly Schutz. The topic is a less than ideal outcome, complications of cosmetic eye surgery and aesthetics. Emily has been in emergency medicine for the last 13 years, has been at Franklin Square since 2019, serving as the lead PA since 2022. And Kelly's been practicing as an emergency medicine PA for 27 years. She works at MedStar Good Sam and our other emergency departments. She's our current director of advanced practice for MEP, and she enjoys procedural and academic teaching and precepting students.
we're going to talk about a few complications related to cosmetic eye surgery and aesthetic procedures. We're going to jump into a few cases first. Our first case was a 25-year-old female. She has basically no chronic medical conditions. She comes in complaining of some right eye photophobia, some tearing, pain. She has some swelling and redness to her upper eyelid. And she's been to multiple other medical institutions over the past couple of weeks. She was diagnosed with several other pathologies, and nothing she has tried has helped. No contacts, and again, as we said, no chronic medical conditions. So when you do your exam, one thing you'll notice here is that on lifting the lid, you see what looks like some type of small foreign body. And on further discussion with the patient, you obviously inquire as to what this could possibly be. Patient then tells you, by the way, that she had double eyelid surgery 13 months ago, but never mentioned it because didn't think it was related. And this is something that you may see in the ER, by the way. These sutures can basically erode through. And when you see this, you may have to actually retract the lid because they will be very posterior, but your goal here is not to remove it. So call ophthalmology, ask them what to do, see if you can get them some follow-up, but do not remove said suture. So our next case is a 59-year-old patient. This is a woman who comes in complaining of some right eye pain and vision loss. She is very forthcoming and tells you that about 6 weeks ago she had blepharoplasty. When you look at her eye, you're going to notice that she has a lot of scleral injection. The pupil is reactive, but she's got this sort of hazy film on her cornea. Her vision is severely diminished. And one thing you will notice here is that she has a hypopyon, which, if you guys all remember from training, a hypopyon is that basically that white fluid level at the bottom of the eye that is typically going to be just an accumulation of white blood cells. And so just for our edification, this is what we call endophthalmitis, and this is typically caused by the accidental penetration or the burn of an eye. There are two kinds. The endogenous is basically something that comes from a systemic infection. It's pretty rare, but there are cases that have actually, there's a few literature cases of patients that have had this related to breast augmentation. So it doesn't have to be necessarily an eye procedure. Exogenous cases are much more common. They are acute if they're less than 6 weeks from surgery. And these are going to be typically our gram-positive organisms. They can be fungal or inflammatory as well. This is considered an ophthalmologic emergency. You want to essentially try not to miss this if you can, because it's really going to change this patient's ability to see in the future. Cataract surgery is our most common cause. Treatment. So for these cases, first call is going to be your local ophthalmologist and hopefully your tertiary care center. You're going to treat them like any sepsis case. You're going to start antibiotics, cultures, don't forget tetanus. When you select your antibiotics, you want to make sure that you're picking something that has some type of ocular penetration, and that would include your third generation cephalosporin, or moxifloxacin is typically the standard for most ophthalmology notes now. You're going to start an antifungal if you're unsure of the etiology or if the patient is somewhat immunocompromised. Consider cytoplegic medications for comfort. And the bottom 2 points, including vitreal cultures, antibiotics, and vitrectomy, are not our problem. So things that we're going to talk to ophthalmology about, but we don't have to do. Okay, and our last case is a 42-year-old female. And this is a woman also with no chronic medical conditions, comes to the ED, says that she has some basically facial pain, she's had vomiting, she's had blurry vision, and also complaining of some diplopia in the right eye. Again, not a contact wearer, no chronic medical conditions. She said on exam, you note that her visual acuity in the right eye is, again, also really poor. It's about 2200. She doesn't have any facial asymmetry. But you notice these sort of ischemic looking marks on the top of her forehead. And on further discussion, she says, as most of our patients do you think it has anything to do with the fillers I got yesterday? So just a little brief note about fillers. These are probably the most common plastic surgery procedure that doesn't include actual surgery. There are about 4 million done annually, and there are 30 different fillers that are approved in the United States alone. Most common currently is hyaluronic acid, and it is considered the safest and theoretically reversible. So this woman has what we call a filler-induced vascular occlusion. These can occur basically within hours to several days, and they're hypothesized to be related to the accidental infiltration of the vasculature. However, just to note, it does not have to be an arterial puncture. It can actually occur from a venous puncture due to anastomosis between the two. And it's considered, basically it can occur by the retrograde embolization into the carotid and facial arteries. There's a lot of debate about how to prevent this. Data currently says that if you inject or if you pull back as you're injecting, we haven't actually improved any safety. Most commonly, this is seen with hyaluronic acid, and that again kind of correlates with what's typically in the market right now. And there are basically 3 areas that you're going to potentially see in the ER. One is skin, one is ophthalmologic, and neurologic. For the skin, you're going to see a patient that's going to present with some pallor initially. This can advance to necrosis and have really debilitating, basically really debilitating course if it's not addressed. The ophthalmologic complications are going to be blindness, potentially ptosis. You might see ophthalmoplegia. You might also see eye pain, redness, vision loss. And these are going to be your basically retinal ischemia, your CRAOs, your BRAOs, your OAOs. And these are really also devastating. Patients can lose their sight, and the evidence currently says within 90 minutes you can have irreversible retinal damage. And then lastly, neurologic are going to be patients that are going to present as a stroke. These are going to be treated just like your regular strokes, but you want to think about this as the cause in a patient that may have a neurologic deficit and has no risk factors. And again, also can have really devastating outcomes. But just to note that patients that had something called autologous fat transfer are much more likely to have a concomitant stroke if they present with vision loss. And this is not considered reversible and also has, again, worse outcomes for patients. Briefly just mention this, filler-induced vascular occlusions are rare. However, they are on the rise due to the increased incidence of fillers. There's about 60 cases worldwide currently, about 60 cases a year projected. However, there's no universal reporting system, so this is probably not correct, probably underreported. About 3/4 of them are all going to be due to hyaluronic acid. And they're going to typically involve injection in these danger zones, which are more likely to result in embolic events, including the nasal area, which is about 40%, 27% of the forehead, and 19% are the glabella. They typically have a more shallow location of the arteries. They're also going to have more anastomoses in these areas. Current recommendations are that there is no truly safe area any longer for injecting. You can theoretically have one of these events when you inject in any location in the face. Okay, treatment. So many studios or dermatologic offices will have a protocol for the skin. However, there are these filler parties, and you may see this patient come in with no treatment prior. You're going to treat patients that come in with either a skin or a retinal issue as a vascular event. They're going to get clopidogrel and aspirin. You're going to try to get a good history, and you're going to ask, again, what was injected, how much, when, and if you can, again, make sure that hyaluronic acid is going to be a better bet, hopefully, with a better outcome. You're going to call plastics for skin. You're going to call ophthalmology, obviously, for the eye. For the skin patients, you're going to mark the area, and then you're going to inject the enzyme hyaluronidase, typically about 1,500 units, and you're going to inject it subcutaneously around the ischemic area. You do not need to inject it intravascularly, but you will probably have to repeat it. The data says 1 to 6 hours, which is a huge range, and you're going to titrate to a normal cap refill. You might need antibiotics, and these patients with skin issues are going to need advanced treatment, possibly plastics. They might need grafts, and hyperbaric oxygen has been shown to be beneficial. Unfortunately, for our patients with the retinal issues, they have a worse outcome, but you're going to treat them again just like you would for anybody who has increased intraocular pressure. You're going to put them in the semi-Fowler position, apply timolol, consider ocular massage. There's lots of other treatments that have been proposed, including IV steroids, acetazolamide versus mannitol. A lot of these are going to be discussed hopefully with your consultant before kind of proceeding. There's also some, again, more advanced procedures involving a ultrasound guided intra-arterial hyaluronidase. But just an FYI, MedStar does carry hyaluronidase. It is available in most of our pharmacies, and you may, it typically, I think, is in 150 unit vials, so you will need a lot of them, but it is available. And that's all.
So the bottom line is history. So we all get a lot of history from our patients with eye diseases and complaints. We typically get history of trauma and vision changes, sometimes even travel or exposure. But as you know, we often have to ask questions, patients the same question 3 different ways to get the right answer. How many times have you said, do you have any medical problems? The patient says no. What medications are you on? They say metformin. So you really want to pay careful attention to asking them very specifically about eye facial procedures, including cosmetics and injections, medications, both over the counter and prescribed, as well as cosmetic, and if they've had any recurrence of the problem. In the U.S., in the Northeast and West Coast, eye cosmetic surgery is the most popular. However, medical tourism is steadily on the rise in the following countries, as shown. And that's because of ease of travel, perceived expertise, internet marketing, and a reported lower cost profile of anywhere from 22 to 88%. Luckily, typically reputable places will encourage a 10 to 14-day stay, so they'd be dealing with most of the immediate postoperative complications. But just note that international surgeries tend to carry higher complication rates and infections with non-tuberculosis mycobacteria. In addition to getting a thorough history, it's really important to know the kind of surgical intervention, because that can help you think through the risk and the type of complications and how to triage these patients to ophthalmology. So looking really quickly at eye surgery complications, there's the obvious cosmetic complications such as asymmetry, malposition, or scarring. And typically you can get some photophobia, change in lacrimation, pain from exposure keratitis, foreign body sensation, chemosis, and hyperemia, but that's typically temporary and immediately postoperatively. Less commonly, wound dehiscence, granuloma formation, infection, and eversion or inversion of the lid, change in direction of your lashes with corneal abrasion or ulcer or damage to the lacrimal system. And it's really rare, but retrobulbar hematoma is reported in about 0.55% of blepharoplasty cases through arterial bleeding or excessive coughing or vomiting after surgery. And we mentioned endophthalmitis as a complication of inadvertent puncture of the globe. Blepharoplasty is going to be the most common surgical procedure, accounting for 200,000 annual cases. There's lots of medical indications for doing it, especially with the elderly, with having some decreased visual access, and then obviously the aesthetic indications. With upper and lower lid blepharoplasty, with the upper lid, you're having transcutaneous excision, so that carries a little bit lower risk. But when you start to involve removing some of the orbicularis oculi muscle to get a little bit of a deeper depth of that crease, that carries a little bit higher rate. The lower lid versus the upper lid, that also carries a little higher rate of complications. The transconjunctival method is the preferred method, but when you start doing fat repositioning or excision, or if you're trying to change the line of the lower lid with a canthoplexic or canthoplasty, that carries a little bit higher complication rate. There's a procedure called the double eyelid surgery. There's 3 different methods for doing that. One is surgical removal, which is fairly easy to remove the excess skin, suture ligation, or a combination of both. As you can see in the diagram with the suture ligation, it's combining the subdermal tissue to the underlying levator aponeurosis. So as you can see, you can have an inadvertent puncture of the globe with that, or an erosion of the suture or suture rupture on the backside of the palpebral conjunctiva. With medial canthoplasty, there's pretty low rates of complication. Just consider that nasolacrimal duct, and it could have complications there. With lateral canthoplasty, there's 1,001 different approaches, some of them including cutting the lateral canthal tendon. There's certainly medical reasons for this, but there's also a lot of cosmetic reasons as well to brighten the eye, change the shape. We mentioned retrobulbar hematoma, but with this particular procedure, lacrimal fistula or drainage problems, because you have the angle where the tear needs to drain from the lateral canthus to the medial canthus, and ideally you want at least a 1 millimeter elevation of the lateral canthus going down into the medial canthus. Injectables, we kind of covered that already, just Botox. We see that pretty commonly, as a side effect, but luckily most of them don't show up in the ER, and those effects are pretty temporary. Medications, most medications, there's a lot of over-the-counter drops, including lash growth medications or even eye color changing medications, which really, don't do a good job, and many of them have been taken off the market. And that's due to a lot of the adverse effects, theoretically through tear film destabilization. And the one to mention is the bacterial contamination. Even something as innocuous sounding as artificial tears can be a problem. In 2023, the CDC identified over 55 patients that had a drug-resistant strain of Pseudomonas infection related to a artificial eye drop, and that resulted in anything from keratitis to sepsis, and there were reported deaths with that. So just ask about any of those over the counter. Orbital procedures, there was a popular procedure called eye whitening to reduce the redness of the eye. Kind of pretty scary to think about, but they would remove the bulbar conjunctiva, and that was followed by application of mitomycin C. That differs from tergium surgery, where autografting is done after the removal. But this was banned in South Korea, where it was originally created because of an 83 to 90% complication rate, and the complication rates were pretty severe. But you can see complications from months to years later. This is a 64-year-old gentleman that had the procedure done 13 years ago, and he had scleral thinning and loss of the conjunctiva there, and he ended up developing a infectious scleritis. He ultimately had to have a conjunctival advancement procedure to cover that area to save his eye. And then lastly, keratopigmentation. You can actually have iris color change. If you don't like your eye color, you can make it as bright blue as you want. There's different methods, corneal tattooing with micropuncture, or there's a new femtosecond laser that does an intracorneal pocket and instills dye in there. And there's eyeball tattooing, which is done by tattoo artists. And scarily iris implants, typically those are usually done for congenital deficiencies, and it's generally considered unsafe for cosmetic use. And YAG laser, that is done for depigmentation, so people that don't have that have heterochromia and want to kind of equally match the eyes, they can use that, but that's pretty new and limited data. So most of us are familiar with WikiM. There's a really great resource. You don't have to be an eye expert. The key is getting the history and knowing what procedure they had done. And there's a great website, iwiki.org. That's very similar to the WikiM that we're familiar with. And you can type in, this is lower eyelid blepharoplasty, and it really goes through all the different surgical techniques and complications. So it's really about having the index of suspicion to know whether you have to have an urgent or emergent referral to your ophthalmology friends. And that's all.
Thanks so much for the introduction, Manish. And yeah, for those of you who haven't met, my name is Ted, and today I'll be speaking about clinical efficiency in emergency medicine. So as Manish mentioned, I graduated from Georgetown Washington Hospital Center residency in 2020. I worked for the first few years out of residency in a highly metric-driven CMG-run community ER in Northern Virginia before coming back to MedStar in 2023. Since then, I've been splitting time at Hospital Center and Harbor, which are two obviously very different practice environments. Along the way, I've picked up some tips and general practices on boosting your clinical efficiency that I'll be sharing with you today. So first, some congratulations are in order. By virtue of being an emergency medicine provider, you are already incredibly efficient clinical machines. When it comes to differentiating sick versus not sick, putting out 8 different fires at once, usually metaphorically, but sometimes literally, and providing life-saving, compassionate care in a timely manner, no one does it better. While our consultants think sequentially, seeing one patient at a time, we are pros at ensuring a dozen or more patients are moving through their ER workups at the same time. The goal of this talk is more about getting you think about getting you to think about small things you can add to your practice rather than a whole redesign. Obviously, I would be remiss not to mention that a great deal of factors that influence our efficiency are system-based and often outside your control. For example, things like lab and imaging turnaround time. But for today's talk, we'll just be focusing on practices you personally have control over. All right, so set the scene. Imagine you have just logged into your computer to start a busy Monday swing shift. There are currently 3 patients waiting to be seen. A younger patient presenting with chest pain who has normal vitals, a 67-year-old female with a GI bleed that EMS is currently bringing into a room, and finally, a 55-year-old male with a relatively low-risk head injury. Where do you start? What's your game plan on ensuring each of these patients are moving towards a disposition and not waiting on you? Before we dive into some tips and tricks, why should you even care about improving your efficiency? Well, we all know that one of the greatest drivers of dissatisfaction for our patients is prolonged wait times. And no matter where you work, wait times are an issue. There's a reason why, regardless if I'm at Hospital Center or Harbor, I usually introduce myself with, "Hi, I'm Dr. Katz. Thank you for your patience waiting." While we are more efficient, we are also happier when we're more efficient. There's a palpable difference in the mood of the entire department when patients are moving through expeditiously. I personally think that one of the most gratifying experiences as an ER doc is when at the end of your shift, you leave the department in a much better state than when you inherited it. Not only are our patients happier, but they're also safer. The sickest or most dangerous patient is often the one in the waiting room that you don't even know about yet. The faster you can get that patient back and seen, the better. Finally, metrics are increasingly becoming core to the practice of EM, regardless of whether you're in the community or in academics. If you checked your bank account last week, you saw the real-world value of RVUs. This year, with the new incentive bonus on dispo time, these metrics are getting even more important to both your patients and your paycheck. But through it all, I want to make it clear that our goal is to be efficient, but not sacrifice the quality of the compassionate care we're delivering. At the end of the day, the most important things are providing excellent care and not burning yourself out. So to start, let's talk about some general principles, beginning with adopting the right mindset. Given the demanding nature of our jobs, working an EM shift can be viewed as an athletic feat. In my opinion, it's a series of sprints rather than a marathon. Just as you wouldn't jump into a race without warming up, make sure you're prepped for your shift. That makes making sure you're caffeinated, hydrated, and fed. I don't always do a good job of this, but I find on the days I do actually bring my own food that I'm much more productive. On those shifts, there's a guarantee that I'm going to eat and that I'm not wasting my time walking to the cafeteria or Panera or scrolling through DoorDash. Starting your shift at a fast clip is key. On my best shifts, I'm usually seeing about half my patients in the first 2 to 3 hours. Obviously, being social is great, but the start of your shift is really the worst time to chat. Try to take sign out as soon as possible to reduce distractions and start sprinting. Particularly early on, I like to see my patients in batches, usually picking up 3 to 4 charts to start my shift. It forces me into high gear when I have the most energy. You should prioritize seeing patients who are critically ill first, and then those without any workups ordered from triage, such as an elderly patient with abdominal pain who's clearly going to get a CT. I'll typically see each of these patients one after another while I'm away from my desk and write all the documentation at the same time when I get back. The key is making sure that all the notes from your first batch are done before picking up another, or soon the amount of unfinished notes do become overwhelming. A good rule of thumb is to always have a plan for a patient's dispo before you've even left the room. Obviously, there are going to be surprises, but you should know what the patient's dispo is going to be if all of your testing comes back negative. That way you can communicate early to the patient the plan, and any barriers to your dispo, like the patient saying, "I don't have my house keys," or "I don't feel safe going home," you want that to come up earlier rather than at the end. As soon as a patient's dispo is ready, that should really be your sole priority to free up mental and physical space. And finally, just like the vasculature of your favorite CHF patient, we all have our breaking point. The more patients you see, the more you accomplish, but this is not infinite. Once you reach your tipping point, you start making errors and patients end up waiting. So know your point of decompensation and respect it. Although most of today's presentation is based on experiences, there is some actual evidence about what behaviors are positively associated with provider efficiency. There was an interesting observational study that took place across several EDs in the US and looked at how specific practices correlated with productivity. They found that average patient load, using the names of your team members, having more conversations with team members, more visits to patients' rooms, and more frequently running the board was associated with more RVUs per hour. So average patient load, that's obviously no brainer. If you're going to see more patients, you're going to generate more RVUs. But as we discussed, each patient has their breaking point. From a social context, knowing and addressing your nurses and techs by name is a powerful tool. If someone knows you by name and identifies you as a valued member of the team, you're going to be much more motivated to go and get a task done. Along those same lines, there's nothing that beats a face-to-face conversation, whether that be with your team or with the patient. As you keep updating the nurse and reevaluating the patient, changes in conditions and obstacles to dispo are revealed faster. This avoids the challenging situation when you go to discharge the patient and they report a new concern that holds up their dispo. Finally, running the board makes sense since you're constantly brainstorming each patient's plan and making sure you're never the rate limiting step. Not surprisingly, they found that 2 behaviors were negatively associated with efficiency: frequency of non-work related tasks and documenting on patients no longer in the department. This piece about documenting does give evidence to support that over time you are going to be faster if you write your notes contemporaneously versus waiting till the end of your shift. My next tip is to delegate. So this is one of the biggest things I had to retrain my brain on as I went from a resident to an attending. Early on, you want to be the doc that does it all, so everyone knows that you're a team player. That's admirable, but there's a reason why the hospital employs nurses and techs and secretaries. Utilize the resources you have, including people that would be happy to help you out. For instance, I think poison control is an amazing resource, but how much time have you spent on the phone with them that could have easily been handled by someone else? At one of the hospitals I work at, our triage nurse calls poison control, saving the doc precious time. I also routinely, but always politely, ask nurses to call the lab or CT to figure out the reason for a delay with their patient's results. The same goes for ultrasound IVs. In stable patients, I will ask that anyone with a skill try before I'm asked to place one. At the same time, I'll empower my nurses by encouraging them to place triage orders on patients via nursing protocols. At Harbor, we don't use MAC 3 for triage, so having some initial labs or x-rays placed by the triage nurse is incredibly helpful. As docs, we are blessed to work alongside PAs that are highly skilled in procedures like IND of abscesses and lac repairs. I find that PAs are often more than happy to help you out if one of your patients needs one of these time-consuming procedures. This frees you up to keep the department moving. This is a little more site-specific, but I also recommend asking for help from your critical care teammates for lines on ICU patients. Obviously, we need to do enough lines to retain our skills, but there may be an APP or a resident from the ICU that is ready and willing to put in a central line. The department will usually benefit from you using that extra time to see more patients. However, there are some things that I never delegate to others. Basic but important tasks like grabbing the patient something to drink or a warm blanket, since that's just called being a nice person. So speaking of leveraging resources, using AI effectively has been one of the single biggest additions to my clinical practice in the last year. Earlier this year, at the recommendation of a colleague, I started using open evidence AI, and it's really been a game changer. But just to make it clear, I have absolutely no financial stake in the company. I just think it's awesome. I found that essentially every medical student I work with uses this tool, as well as most residents, but only a few attendings know about it. So it's basically ChatGPT for medicine, but in contrast to ChatGPT, which pulls from the whole internet, open evidence draws only from peer-reviewed medical journals and guidelines. It's designed to give you quick, evidence-based answers to questions, complete with citations, all for free. You just need to log in with your MPI number. Doximity just came out with their own version, and I just saw UpToDate is now demoing their own. For example, I recently had a patient with known cirrhosis who came in with MSK back pain. I had no idea which muscle relaxant would be safest, so I just asked the robot, and here's the answer it gave me in about 3 seconds. I find it to be much faster than digging through pages of UpToDate. You can also use it to come up with differentials or even have it perform tasks like creating detailed discharge instructions in other languages. One point of caution is just like with any other resource, AI is not infallible. It's best used as a tool with you, the clinician, critically appraising the information to outputs before putting into practice. My next tip is to avoid ordering tests that won't change your management. Sometimes these tests are ordered as a holding pattern when you're not sure what to do with the patient. In those cases, it's better to just spend more time at the bedside figuring out what's going on. Other times, you think the patient won't be happy without a test, but more often what they're really looking for is a thoughtful conversation and reassurance based on your exam. Let's start with spinal x-rays, which I still see ordered a fair amount and really have no role in the ER at this point. We all know spinal x-rays have poor sensitivity for pathology, and lumbar x-rays actually have a fair amount of radiation, almost as much as a head CT. If there's something that concerns you to the point you can't just discharge the patient based on your exam, then go straight to CT or MRI. I'm certainly guilty of this as well, just like most people. But another test that often hurts our efficiency is the CT head in uncomplicated cases of syncope or headache. So learn and apply decision rules like the Canadian head CT rule and the Ottawa subarachnoid rule to reduce your imaging. For syncope patients who are coming in without headache, who haven't had a head injury, the yield of a head CT is incredibly low. If you're admitting the patient, it's true that many of your hospitalists might require a CT, but I find it better to at least try to admit them if you don't feel the head CT is indicated and just see what the hospitalist has to say. The next time you're sitting waiting for your patient to produce a urine sample, you might also want to ask yourself, why do I even need this? Particularly in younger patients, if they don't have urinary symptoms and you wouldn't treat it, then just don't wait on the UA. Finally, some examples of tests that often won't change your management are listed here. So I used to always obtain a TSH in my patients presenting with palpitations, but I found that when they have a normal exam, they have normal vitals, the yield is incredibly low. The evidence supports this, as one study found that in ED patients with isolated palpitations, only 0.2% of those patients were given a new diagnosis of hyperthyroidism after undergoing thyroid testing. So I think most of us at this point have heard of the term swarming, but just to review, this is a relatively new model that centers upon the immediate evaluation of the patient by the entire team, including nurses, techs, and both the learner as well as the attending. One of the benefits is that the resident and attending come up with a game plan together at the bedside. This is then communicated to the whole team. One study found that this model was associated with significant reductions in patient length of stay, door to doc time, and left without being seen rates. However, particularly in an academic ER, like at hospital center where I work, there definitely are competing interests between efficiency and providing autonomy to learners. This model can reduce the time spent playing telephone between student, resident, and attending, but you have to be mindful of not taking away your trainees' autonomy. Some strategies are to use this more with junior residents, and if you are going to be in the room, then just make sure you're quiet, you're in the back, and you're just observing until the resident gives you their thoughts. I've also found swarming to be highly effective in the community, like where I work at Harbor. Whenever possible, if EMS is unloading a patient, I will get in there to hear the report firsthand and start examining the patient. Discussing the plan with the patient and your nurse at the same time, make sure everyone is on the same page. This strategy also prevents the common issue of having to roam the ER, trying to find the patient's nurse to chaperone a pelvic or rectal exam. In this model, the whole exam is performed immediately with the nurse present. In my opinion, one of the biggest detractors from our efficiency are the constant interruptions we face. According to one study, ER docs are interrupted on average about 12 times per hour. While we pride ourselves on being expert multitaskers, the truth is that multitasking is a myth, as your brain can only really perform one task at once. Therefore, what we're really doing is task switching, and all this time switching back to your original task really adds up. One strategy that can be effective is to bundle your tasks to limit your exposure to interruptions. For instance, if you can write your note either in the room or on a WOW directly outside the room, it'll prevent you from being interrupted. When you get up from your desk, try to be as productive as possible, knowing this is often your best interrupted time. Be purposeful with your steps and even the route you take around the ER. Go do multiple reassessments on patients, when you're up discharging someone or on your way back from grabbing a snack. It sounds funny, but I often walk awkwardly fast in the ER, which I feel sometimes will reduce how frequently I'm interrupted. And then when you're standing at your desk, standing can actually be a subtle indicator to others that you're busy and need time to focus. If you are interrupted while performing a critical task, like placing a medication order, it is completely reasonable to ask the patient to wait. It's rare that a question can't wait the 30 seconds for you to finish your task. Finally, other than EKGs and calls from the lab, most of our interruptions are questions regarding patients from nurses and techs. Rather than waiting for questions like, can this patient eat? Be proactive by constantly updating your team on the plan of care, including using the tracking board. Okay, so now putting it all back in practice. So to start your shift, you start off at a sprint by picking up all 3 patients. You first go see the most critically ill patient and swarm them with your team. You get report from EMS, you perform a rectal exam while you have the nursing team to chaperone, you get the patient's consent for transfusion, and communicate the plan to the whole team. You place orders right outside the room without being interrupted. The younger patient with chest pain has labs and a chest X-ray ordered from triage that are still in process, so you decide to go see the patient with a head injury. Given he is low risk per the Canadian head CT rule, you're able to discharge the patient after a thoughtful conversation rather than pursuing imaging. Finally, you go see the younger patient who has chest pain, whose workup has now been completed. You evaluate the patient, go over his normal test results, and let him know he will be going home. You then finally return to your desk where you discharge patients 1 and 3 and admit patient 2 now that the labs are back. You write all 3 notes and are well on your way to an efficient, satisfying ER shift. Here are my references, and thank you for listening.
Yeah, that was fantastic. Thank you so much. Any questions for our presenter?
Yes, Tanya.
Yeah.
So what do you do when do you review the chart to look for kind of history? Because a lot of our patients just aren't able to provide a lot of great history. So do you do that after you've talked to them, come back to your desk and you're writing your note?
I usually do that a little bit before. So, if I see they're like, obviously at the beginning of your shift, there's a bunch of patients, I like to at least get my name on them so people know that I'm going to pick them up. I let, the other provider have a second to breathe. And I do a quick chart biopsy. At Harbor, we get a lot of patients who sometimes are from other hospitals, due to issues with that hospital, like they're on diversion, they've never been to RB before. So you have to do a little bit of a chart biopsy. But I find that there's a balance. Like you can't go too in depth because they may be there for a completely unrelated reason, and you may have just wasted 10 minutes of your time reading about their prior cath when they're there for ankle pain. So I think doing a real quick biopsy, at least getting like some of their medical history, figuring out if they are blood thinners, things like that, and then diving in and then looking in more detail when you get back.
Great. Jamie?
Hey, Ted, awesome talk. I love those tips. I particularly like the swarming one. I'm going to start trying that. I wanted to offer one point of caution. And
Jamie,
maybe this is me. The rest know I'm grumpy about open. Without going is it's matching one word to the next word by probability. And it will always give you something that sounds correct. That's what it does. It makes it sound good. It has no real concept of what it is actually saying. So if you're using it and it spits out something that looks right, and if you don't know enough to tell what's wrong, you very commonly go down a path where it's incorrect. So you need to be real. I would encourage to use it, and often you will see it be wrong. It's great to like go find sources and stuff, but again, just proceed cautiously. That's all.
Sure, I think you break up a little bit, but so we were talking about open evidence, and yes, definitely use it as a tool. I think it's best used when you have that base of knowledge and you're able to almost confirm what you're reading. You're like, I think this is like the right dosage for medication. I just want to confirm it, and you're like, this sounds right. The good thing about open evidence is it does link you to guidelines and articles. So, if you're ever unsure about the recommendation, you can at least click there and it'll give you what it's actually drawing upon. But you're exactly right to use it as a tool that matches kind of what you internally know is right.
And Ted, there's another question in the chat. If it's okay, I'll ask you to pull your slides down so we can get our next presenter going. Running a little bit behind, but just an awesome talk. So good. And you might have seen in the chat, you may not have because you were presenting, but several people commented you're the perfect person to give this talk. And I think we all feel that way having heard it. This should be given on a national level. That was really outstanding. So thank you for giving
really
that.
Nice of you guys. I really appreciate it.
All right, our last presenter of our morning Fall Symposium is Dr. Max Hockstein, talking about wall motion abnormalities on echo. Max, as many of you know, was a former tech in the hospital center emergency department. Subsequently went to med school in EM residency and did a critical care fellowship, and is now attending both at the hospital center ED and the Heart and Vascular Institute as an intensivist. And he's talking to us about regional wall motion abnormalities on echo. Max.
So today we're going to talk about one of my favorite parts of echocardiography that doesn't get a lot of airtime in the emergency department, which is regional wall motion abnormalities. So the reason that we care is because ECGs come in looking like this, right? A patient has some tepid story of chest pain and may or may not be exertional. This ECG has some abnormalities, but is by no means slam dunk type 1 ACS. AVF has some terminal T wave distortion, and like maybe lead 3 is a little bit awkward, but by no means is this ECG going to get anyone to a cath lab. And although I love electrocardiography, it's kind of a late finding in the ischemic cascade. So as soon as a patient experiences a perfusion defect, one of the first things that you start to see is first diastolic dysfunction, and then you see a regional wall motion abnormality. Chest pain and dyspnea is the very last finding in the ischemic cascade, and we are using the thing that happens right before that. So we're relying on a relatively late finding for acute coronary syndrome. So when we use echo to diagnose acute coronary syndrome or to help us diagnose it, you're actually using a much better metric than the relatively blunt metrics such as troponin or chest pain or ECG findings. So by way of anatomical review, the heart sort of looks like this, not all of our hearts, because the hearts actually lay different ways in different people's chests. We have 3 levels of the heart. I want you to think of the base as close to the top near the aortic valve. There's the midsection somewhere near the papillary muscles. And then there's the apex, which is closest to the chest, lateral chest wall. And the way that we're able to see this and interact with it is by echo. And so this is what's called a basal view, where you see the aortic valve in the middle, and this is a short axis. To review, a short axis is if you think of the heart as a loaf of bread. A short axis is slicing a loaf of bread like you're going to make peanut butter and jelly. So right here in the middle, you have the aortic valve. You'll see the Mercedes-Benz sign. And at the very, very top, you see the right ventricle. I don't want you to think about this as the right ventricle. I want you to think about this as the anterior ventricle. The anterior ventricle, and this has consequences in both electrocardiographically and by echo. And so if you go a little bit more apically, you get what we consider as the more classic peristernal short view, where the LV looks like a donut and the RV looks like a croissant. And you can see that the septum is nice and curvy and it's midline. And then when you move a little bit more apical, you lose the papillary muscles and you get really only a sliver of the right ventricle. And this is really just an LV apical shot. So the most common view that we get in the emergency department, and what is arguably the easiest view to get, is the peristernal long view. And there are several ways that people interpret the peristernal long view. But for us, I actually want you to think about it like home base. Anytime you are lost in an echo, go back to your peristernal long. And so if you take 90-degree cross sections of your peristernal long, and if we are to indulge again in the bread analogy, a peristernal long is if like you're making a sub. Like if you go to the store and like a serial killer, you slice the entire loaf of bread down the middle, and that is your sub. That's your long axis. So if you take an orthogonal view of the apical portion of your long axis, you'll get that apical shot of your short axis. And then if you cut through the middle of your long axis, you will see a perfect peristernal short axis. And the peristernal short axis is canonically done with the papillary muscles because it is the only shot in all of electrocardiography that has all 3 coronary artery distributions. And if you go a little bit more apically on your long axis, you have the view we just saw, which is the aortic valve or more basal view. Perhaps the most difficult view to get, but often the most rewarding and one that can give you a ton of information is the apical forechamber. We recall that an apical forechamber perfectly splits the shot of the heart down the middle, with the right heart much smaller, but just as important as the left heart. And if you slice a little bit apically, you'll get that apical shot of your short axis. Your mid-pap view right there, and of course your aortic valve view. Now that we know all the anatomy, we have to talk about function. So what in the chat, what do people look for on an echo that say function is good or function is not good? And when people often say squeeze, but what exactly are you looking at? Are you looking at the cavity? Are you looking at the muscle? Are you looking at stuff around the heart? Dr. Mueller's doing fractional area of change, really indulging in the whimsy in a older echocardiographic metric that we still talk about. So when we talk about contractility or squeeze, it's very tempting to look at how much the cavity changes size. So in the picture in front of us, what you see is that the cavity nearly obliterates, that the muscle kind of gets rid of all of the hypoechoic blood in the middle. And that's okay. But to refine this, what you can do is look for muscle thickening. Normally in systole, the myocardium thickens by about 30%, and that is normal contractility. But if you're looking at just the very middle, it's hard to look at each wall segmentally. So anytime you're looking at a short axis, in your mind's eye, I want you to draw a little dot in the middle. And when you draw that little dot in the middle, you should see all of the walls come together at the same time approaching that dot. And if the walls are thickening, it will approach that dot altogether. We also recall that the probe is at the very, very top of the screen. And so what is anterior is closer to the top of the screen, and what is posterior is at the lower half of the screen. And so while we know that to be true, the heart is on an axis. And the implication here is that the anterior wall is a little bit more like northeast than true north. And so this is a parasternal short view, and the A denotes anterior. So anything to the right of that red line is your anterior wall, and anything to the left is your inferior wall, which a lot of people will call your posterior wall. The other cardinal direction that you need to know is what is septal, towards the interventricular septum, and the other is lateral, towards the LV lateral wall. And so these are really the cardinal directions of regional wall motion abnormalities. And you can have anteroseptal, anterior, anterolateral, similar to north, northeast, etc. And so we talked a little bit earlier about how this view is so important because it demonstrates all three coronary artery distributions. And the way that we see this is that the RCA perfuses the RV here and all of kind of this infero-posterior wall here. The circ, which is notoriously difficult and almost silent on a lot of 12 leads, is the lateral wall here. And the LAD supplies a lot of your anterior wall and your anterior septum. So if we think about this, how we will approach it from an ECG perspective, any at ECG abnormalities in leads 2, 3, and AVF is typically RCA territory, and often a little bit of the circ. So 2, 3, and AVF will be the RCA distribution. V1 and V2, because they are parasternal right and left, will be the anterior wall. And the septum, we recall, is split in two blood distributions, a little bit of LAD for your anterior and a little bit of RCA for your inferoseptal. The circ, again, very difficult to find on a 12-lead ECG. Circ lesions are on their best day annoying. If you see it on a 12-lead, it's V3 through V6. But often they're electrically silent, which is why looking for a regional wall motion abnormality is so important. Now in the apical view, and I want you to think about this as in a perpendicular view, almost sitting straight upright, you will see leads 1 and AVL here on the lateral wall. So when we put all of this together, you can very easily discern that if you know where the leads on the chest for a 12 lead are, you know exactly where your regional wall motion abnormalities are. V1 and V2, parasternal right and left, about the third intercostal space anteriorly. V6 is mid-axillary with the rest of the leads distributed in the middle. So there are several different types of regional wall motion abnormalities. A normal wall motion is thickening by 30%, which is surrounded by a similar wall motion. The next part here is what is called hypokinetic, where you don't see a wall thickening by 30%. In the chat, now that you know all of the cardinal directions, where do you see a hypokinetic wall? So I see one vote for septal. So this is a little bit of an apical shot, so you don't get a great shot of the septum. That said, you can see the septum thicken a lot during systole. So what I see here is that the inferolateral wall right here is kind of along for the ride. You see up here that the septum likes to thicken, the anterior wall is moving a bunch, and here kind of inferolaterally you don't have a lot of wall motion. So if I put my mouse in the middle here, what you see is that the inferior wall and a little bit of the lateral wall isn't approaching the center of the LV the way that the rest of the walls are. And so that is what's called hypokinetic. Akinetic is where the wall doesn't move at all. So where do we see a wall not moving on here? Absolutely. I see a vote for anterior wall. Yeah, the anterior wall is totally out here. So you see the anterior septum and the anterior wall are really not being good members of society, contributing to systole, because you can see that the lateral wall and posterior wall are approaching the center of the LV, but the anterior wall really not so much. And then there's dyskinetic. And dyskinetic happens when the infarct is nearly completed. And what happens is that the pressure in the left ventricle goes up. And when the pressure in the left ventricle goes up, it will create a paradoxical motion of pushing the LV wall outwards. So when the LV squeezes here, what you can tell is posteriorly that the posterior wall starts to get pushed away from the center of the LV. And the reason this starts to become a problem is when this happens, the myocardium starts to thin. And most commonly, this happens farthest away from blood supply. And what that is what's called an LV aneurysm. So this is a horrifying shot of an apical four-chamber. And what you see is something called spontaneous echo contrast, or you'll hear us refer to this as LV smoke, where the blood is moving so slowly that individual blood waves can reflect off of the ultrasound waves reflect off of the blood cells. And so this is typically after a completed infarction where the thinned myocardium is starting to balloon. And the reason this makes us really nervous is that if this ruptures, the patient can develop tamponade and have a very high morbidity burden. So we talk about acute coronary syndrome as almost synonymous with a regional wall motion abnormality, but that's not entirely true, as we'll see in a little bit. A lot of different disease states can have a disparate impact on certain parts of the heart. So this is the typical complaint that we'll get, right? A patient comes in with a bunch of stuff. They may or may not have chest pain. Of course, they're allergic to sodium bicarbonate. And the important part is that you're considering ACS or you're considering myocardial involvement with really a tepid ECG. So the first patient that you see has this finding. Where do you see the wall motion abnormality? You should not be afraid to answer in the chat. Regional wall motion abnormalities for me is probably one of the more difficult parts of echocardiography, and I still get them wrong sometimes. Be not afraid. So we see a cursor in the middle here, and so we can see here that the posterior wall is approaching it, and you see the posterior septal wall. What do we see here? I see a hypokinetic anterolateral wall. And so again, put your cursor kind of in your mind's eye in the very middle of the tracing, and you'll see that the anterior wall is not moving the same as the rest of them. This is a different patient and with a much more extensive disease. What you can tell, again, you have a perfectly on-axis shot here where you have the two papillary muscles that look like boxing gloves approaching each other. So you can see here that the posterior wall and lateral wall are moving quite nicely, but the anterior and anteroseptal walls are completely out, which raise concern for a proximal LAD lesion. So this is not a short axis. This is a peristernal long view where you can see the patient has marginal LV function at best. Where do we see the regional wall motion abnormality? And so we recall that at the very top of the screen here, you're more anterior, here's more inferior. So where do we see the regional wall motion abnormality? Absolutely. So I see one vote for a posterior injury, and another for apex. So one thing about the peristernal long view, we often can see the apex, but by no means is it required to see the apex on a long axis view. Seeing the apex on a long axis is a little bit tough. Because when the heart beats, it can actually have a little bit of translated motion side to side. So your apex can kind of pop in and pop out of view. So if you were looking to evaluate the apex, you want to do that on an apical shot, not necessarily a long axis shot. But I agree that the posterior kind of inferior lateral wall here is not moving. You can see the septum thicken a lot during systole, but down here, it's really just along for the ride. And so this entire inferior lateral wall is out. And now for an apical shot, my question to you is, what artery is occluded? Well, we can see here that the very proximal septum is moving a bunch. But when you get down to the apex and the very, very distal septum, not much is happening here. The apex doesn't thicken at all. And there almost looks to be like a hinge point here where they transition from like normal septal thickening to almost no septal thickening, very, very distal in the septum. And so this is often a distal LAD lesion. And this is a relatively classic echo. So we talked very, very early about the three levels of the heart. And we talked about the three levels being the apex closest to the chest wall, and then the base close to the aorta. So my question to you is, where is the regional motion abnormality here? Is it more basal or is it more apical? We recall that the apex is all the way up here and the base is a little bit more down here towards the LVOT.
I'm going to say basal because I'm brain.
And I'm going to agree with you. Absolutely. The base here, I heard a voice. I guess I hear a lot of voices. But yes, the voice this time told me that the base is out. And I totally agree. The basal and inferoseptal wall up here is not thickening almost at all. One thing to be careful of for these patients is they fall apart pretty quickly. The posterior wall is very difficult to visualize on echo. It's better visualized by TEE, and it contributes a fair bit to systole, like 30 to 40% of your stroke volume. And we're back to a peristernal short here. What catches your eye first?
Doesn't really appear to be changing size.
Yeah, the LV cavity isn't really, is not doing what it's supposed to do. It's supposed to kind of be contracting almost concentrically, and the hypoechoic area of blood in the middle of the LV isn't really changing size. The the papillary muscles are indeed not getting together. They're kind of in this weird standoff from like all the way across the left ventricle. And so that is an outstanding observation, and in fact leads us to the diagnosis, where you have your inferior wall in the RCA supplying your posterolateral pat muscle, and you see your kind of lateral wall here is hypokinetic, and more so your inferior wall is akinetic. And so this is a circ lesion and an RCA lesion. So indeed, the first thing that you saw, Dr. O'Mara, papillary muscles aren't really doing very much, totally nailed the diagnosis. And now I think in sepia, we are back to our apical forward chamber view. Where would you describe that the septum is regionally hypokinetic? Is it at the apex, midsection, or base? I agree, kind of the midsection here. You can see that there is a good endocardial border definition. It gets a little bit thick down through here and up through the LVOT. It thickens quite nicely, and I totally agree. It almost looks like there's like a divot that was kind of like bit out of the septum here at the midsection, almost at the insertion point of the chordae. Now, what about this one? So again, first thing I do is I kind of point in my mind, I put a dot or a cursor in the middle of the LV cavity, and I ask myself, are any of the segments not coming in towards the middle of the ventricle normally? And indeed, everybody here is correct. There are no regional wall motion abnormalities here. And if you're looking for regional motion abnormality, often a lot of people will see them. Kind of like if you look at an ECG long enough, you can probably find a delta wave anywhere. This goes to show you that if you're looking for it, you can often find it. What's most important is your pretest probability, is that if your patient sounds like they have acute coronary syndrome, you use this to support your diagnosis. So this is an ECG this is an echo. This is an echo of a patient that came in with crushing substernal chest pain that radiates to their entire body. It's ST segment elevations in 2, 3, and AVF, and the patient looks awful. We put a probe on, and where do you see the regional abnormality here? Absolutely. This is a classic inferior wall regional motion abnormality where you see the posterior wall here is just doing absolutely nothing. But the clinical picture didn't fit entirely. So this is a little bit more of a basal long axis view, closer to the aortic valve. Why does this patient have inferior wall changes?
Is that a dissection flap?
That is a dissection flap that was occluding the right coronary ostia. Now, what you see here is the right ventricle at the very top of the screen. Right here, a little bit of fluid in the transverse sinus indicating impending tamponade. And you can see this dissection flap here in the mid-ascending that's right next to the right ventricle. This was a retrograde propagation of an aortic dissection flap occluding the RCA ostia. For the sake of clarity, please do not send this patient to the cath lab. They do not need their RCA stented. Please send them to the operating room as fast as you can with your on-call heart surgeon. What you also will notice is that there's an element of a type B dissection. As was indicated earlier on one of the videos, the descending aorta is a very important landmark in your peristernal study. And you can see a dissection flap moving with the cardiac cycle down here in your long axis of your descending aorta. So one patient comes to your emergency department with some chest pain and some right hand funny business. They got a head CT from triage because they did not listen to Dr. Katz's lecture. This is not an echocardiogram. This is a non-contrasted head CT where we see a hyperdense MCA on the left side. But what about the chest pain? So someone does an echo. Where is the regional wall motion abnormality?
Is that apical mass?
Other than, I'm sorry, say that one more time.
Is that apical?
The apex is totally out. I don't see the apex thicken at all. And anytime you see an apex not thicken, I want you to be scared because the apex likes to hide thrombus. And when the apex is very far from its blood distribution, its origin, and so it is often the first thing to become hypokinetic in LAD disease. And as we know, when a wall gets hypokinetic or akinetic, it can be a risk for thrombus. And so clot loves to hide at the LV apex. And so often, when strokes are cardioembolic, you will see a regional wall motion abnormality at the apex. This is a little bit less subtle of the apical abnormality. What do we see here at the apex?
Thrombus.
Something really horrifying. Yes, this is very organized, big clot. And so please start this patient on anticoagulation as soon as you are able if there are no other contraindications. And for one of our last cases, because there's only one person standing between you and lunchtime and I know better, this is a patient that came in with some chest pain. Where is your regional wall motion abnormality? Yes, it is the RV. And so this is what is called a classical McConnell sign. So where you see a complete RV hypokinesis, nearly akinetic up at the base, and you see a hyperkinetic apex. Now, the apex itself really isn't hyperkinetic. It's because the LV is relatively unloaded because the RV is squeezing it down. And so the LV is pulling the apex all the way over to itself. And it wouldn't be an emergency medicine conference if we didn't reference pulmonary embolism at some point. And so the McConnell sign was originally described with hemodynamically impactful PE. But please remember that this can happen with any right-sided disease, any flavor of pulmonary hypertension or proper RCA infarct. So I want you to look at the entire echo picture. Convince yourself that a regional wall motion abnormality is there. Often you need a whole bunch of views to confirm that your regional wall motion abnormality is seen throughout pictures and make the patient's presentation make sense. No decision in isolation often results as a result of the echocardiogram. If your patient comes in with a myriad of symptoms, the echocardiogram is unequivocally helpful in determining the etiology of your patient's chest pain and often their presentation in general. And with that, thank you so much for not falling asleep. I am here for all questions.
Thanks, Max. The first question is Alex.
Thanks for a great presentation. I love the practice. That actually was super helpful to help me get a little bit more confident with the regional wall motion abnormalities. I guess I was wondering, are these regional wall motion abnormalities specific but not sensitive? And also, is there a timeline? Because I feel like I just had a patient with exertional dyspepsia the other day, 24 hours, now feeling a little bit better, but ended up having an obtuse marginal occlusion. I guess my question is, and his echo looked fine and I'm not great. So his echo looked okay by my look, but if I don't see a regional wall motion abnormality, is that I can't take it off the table for ACS? And then number two is the symptoms of that's 24 hours of symptoms that are exertional. Should I have seen something by then? I don't know.
Well, it depends on how bad the lesion is. Often regional wall motion abnormalities happen with only a little bit of insult of myocardium. It's pretty sensitive. I would say that if there's no regional motion abnormality, my concern for ACS drops. And that said, if you have a patient with stuttering chest pain, the degree of their vascular stenosis may not be consistent enough or severe enough that it produces significant ECG or echo changes. This is the point of a regional wall motion abnormality is to talk about the timeline of the ischemia. And so if you have a densely hypokinetic wall, we assume that it's been ischemic for a little bit of time. Now, if it is dyskinetic or aneurysmal, the infarct is likely completed. And so when you see a regional wall motion abnormality, it's probably hours to days old, with a lot of give on the margins.
Thanks.
Duncan.
Max, that was such a great talk. Thank you so much for giving it. I was wondering if you could talk a little bit about the following situation. You have a patient with chest pain, a non-diagnostic EKG, and an echo with a wall motion abnormality that really raises your suspicion for ACS. And I'm sure there's a lot of variability, but at that point, are you typically calling cardiology and pushing for intervention, starting medical management, kind of waiting on troponins? Can you sort of talk a little bit about how you proceed at that point?
So this is a scenario that we all find ourselves in a couple times a shift, where we believe the patient has acute coronary syndrome, and there are other people that have not seen the patient that believe they don't have acute coronary syndrome, and in the balance hangs the patient's dispo. I used the regional wall motion abnormality to raise my concern for ACS. So it sounds like the patient that you described, you're pretty sure that they're having a heart attack at some point. So I actually use a regional wall motion abnormality to call cardiology and say, listen, this is a guy that deserves intervention. That said, it's about the risk of the ECG changes. If you have high risk ECG changes, which is to say some ST segment elevation, any dynamic change at all, that pushes me a little bit more aggressively towards insisting towards intervention. If I do not have a regional motion abnormality, but a really good story, those are patients that I think are fine for observation. You wait for the troponins and discuss whatever is institutionally most appropriate pathway. But if I see a regional wall motion abnormality with even a non-committal ECG, they don't need a cath right away. But certainly this is a patient that I do not let go home without appropriate investigation. And whether that is a coronary CTA, whether that is a left heart cath, there's a lot of data that leads to equivocation on the right test at the right time.